Thank you, Dr. Mastroni. And again, it's a great pleasure to be part of this symposium. I have no relationships to disclose. So if we think about this, the U.S. and Europe is much different in terms of many things, language, history, art, food, and wine, of course. But we also share some things in common, and that is if we look at the demographics of the causes of death in both countries, we find that Italy and the United States share cardiovascular disease as the leading cause of death. And of course, one could choose any other Western nation in the Western Hemisphere or in Europe, and also in developing countries, India, China, many countries in sub-Saharan Africa have this burden of cardiovascular disease. Much of that is ischemic heart disease and atherosclerosis, of course, but cardiomyopathies are very, very prevalent. We all know that. That's why you're here. My understanding is that 3% or greater of the population has a genetic prevalent predisposition for a cardiomyopathy, and of course, many of the dilated cardiomyopathies are acquired as well. And so we are now have an opportunity, as we've heard already in our opening session, for the convergence and teamwork of cardiologists, cardiac surgeons, cellular physiologists, molecular biologists, geneticists, and also patients and policymakers. In the United States, we've been very active through the organizations such as the Hypertrophic Cardiomyopathy Association in driving policy to cover the implantation of ICDs in asymptomatic people, and in covering insurance coverage for genetic testing, and also protecting individuals who have genetic testing from the information becoming open to insurance companies or employers. And we're also in the era now where we can also develop teamwork for clinical trials, as Jacopo told us. And much of this could be international. And I think for the most part, there's great agreement as to the issues, the understanding and lack of understanding, and also some of the debates. And so if there's understanding on the part of most of us, and clearly the patients are the same, where are the differences? And so I'll just hearken back to where we began this session with Dr. Elliott's comments about the classification of cardiomyopathies. Because here I think we do have different takes and different perceptions on how to approach at least the classification of disease given the diagnosis. And as we heard earlier, in the European classification, it's a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary disease, hypertension, valve disease, and congenital heart disease sufficient to cause the observed abnormality. When the U.S. writing group was put together, chaired by Dr. Marin, it was a very innovative new way of looking at the possibilities, now defined as in this statement as a heterogeneous group of diseases of the myocardium associated with mechanical and or electrical dysfunction that usually, but not invariably, exhibit inappropriate ventricular hypertrophy or dilatation, and are due to a variety of causes that are frequently, but not always, genetic. Cardiomyopathies are either confined to the heart or are part of a generalized systematic disorder, often leading to cardiovascular death or progressive heart failure-related disability. So totally different outlooks, and realizing that there's not only debates between Europe and the U.S., but debates within Europe and the U.S. as these statements get played out. And I totally agree with Dr. Elliott that the phenotype is important, but understanding what may cause dilatation or hypertrophy, or thickness at least, is key. And so I'll harken back also to the figure you saw earlier. The writing group from the U.S. defined the primary cardiomyopathies as either being genetic, mixed, or acquired, and then a long list, which is incomplete here, of the secondary cardiomyopathies. This list could go well beyond the height of this slide. Interestingly, the group also included the channelopathies. other inherited abnormalities that may not lead to alterations in structure or function, but could lead to very serious rhythm possibilities and the risk of sudden death. This was also, I think, innovative, interesting, controversial, debatable, etc. In the European look at things, one has the classical subdivision according to the phenotype and the morphology. Interestingly, for me, as a person who living in the United States and treating patients who we believe have a genetic disease of hypertrophic cardiomyopathy, usually involving the sarcomeric proteins, but not always. There's a long list of conditions here that are termed to be hypertrophic cardiomyopathy, where a sarcomeric protein mutation is just one of many other possibilities, whereas in the US view, that's the disease, that's hypertrophic cardiomyopathy. Whereas in the US, we would not consider glycogen storage disease or mitochondrial cytopathies as being truly hypertrophic cardiomyopathy. The presentation may look similar, echocardiography may be similar, but what is the disease that we're telling our patients they have, and what is the treatment, et cetera, that one needs to go through. And similarly, one now can find that there are differences also in how the infants of diabetic mothers are considered on both continents, as well as amyloidosis and a number of other conditions, including nutritional abnormalities such as carnitine deficiency and other situations such as Noonan's syndrome, Friedreich's ataxia, and so on. On the other hand, I think there's great similarity in the discussion regarding what constitutes a dilated cardiomyopathy or a arrhythmic right ventricular cardiomyopathy. Unclassified in the European writing group is more specified in the US writing group, that left ventricular non-compaction is believed to be genetic, whereas stress-provoked Takotsubo, although maybe unclassifiable, is certainly acquired. In the restrictive cardiomyopathies, again, quite similar outlooks, and I just highlight this because if I need to talk also about beyond the US and Europe, one disease which is acquired and endemic in some parts of the world, but not in the US or Europe, is endomyocardial fibrosis. Dr. Macombe's paper, shown here, points out that in many countries in South Africa, southern part of Africa, that this is a cause of 20% of the heart failure one sees, similar to what one sees with rheumatic heart disease. And so depending upon where we are in the world, the acquired forms of cardiomyopathies may differ greatly, whereas I believe we're dealing with the same genetic substrate across the globe in terms of the genetic abnormalities that may lead to either hypertrophic, dilated, or restrictive cardiomyopathy. And that leads to, I think, the nice review by Hugh Watkins that Carolyn showed earlier. She showed a modification of this. I like this because it shows the overlap that we deal with, as has already been discussed this evening, where the same gene abnormalities may lead to different phenotypic expressions. So the overlap between dilated cardiomyopathy and hypertrophic cardiomyopathy, patients with non-compaction overlapping possibility, both dilated and hypertrophic cardiomyopathy as well. These are at least dealing with the genetic forms of cardiomyopathy. Now, in dilated cardiomyopathy, we also deal with the treatment of this condition. Most of these patients have symptoms, heart failure. Here we can fall back on guidelines from both the US and Europe for the treatment of left ventricular systolic dysfunction. And if you go through these guidelines, one finds very, very similar thoughts regarding diagnosis, what diagnostic tests to do, as well as the drug treatments, and even the indications for implantable devices such as defibrillators or biventricular pacemakers. Although those recommendations are similar, I think that the implementation of device therapy is much broader in the United States and much more heterogeneous in various countries in Europe. In hypertrophic cardiomyopathy, also similarly, we have now guidelines developed in the United States where one wants to deal with the pathophysiologic mechanisms that we've been discussing: outflow tract obstruction, diastolic dysfunction, myocardial ischemia, and arrhythmias, with the goal of either improving symptoms and quality of life in symptomatic patients or reducing the risk of sudden death in all patients. And here, again, we now, for the first time, actually have guideline statements from the American College of Cardiology, American Heart Association. Jacopo could point out quite easily that the evidence base underpinning many of these recommendations is lacking, and many of the recommendations are level of evidence C. Dr. Gersh and Marin chaired this group, and I can tell you there was enormous debate over virtually every topic and every recommendation within a committee ostensibly of experts. And you can see how this will play out into the community management of patients based upon these guidelines, where we're dealing with many physicians who are perhaps less expert. I was not aware of a European scientific statement recently, although Philippe and others in the working group could tell me if I'm wrong, and perhaps you may want to go back and look at this yourself. The last one I could find was the much earlier, almost 9-year-old statement between the ESC and the ACC. So it's not strictly a European document, but one that's shared jointly across the Atlantic. I don't intend to necessarily recite this graph, but this just shows you the complexity of management of patients with HCM. This comes from the ACC-AHA guidelines, but a very similar diagram shows up in the much earlier ACC-ESC document, perhaps because Dr. Marin was the lead author of both of these. This is dealing with the patients who have obstruction. One gets into an even more complicated way of looking at things in patients with non-obstructive disease. But clearly it's a complex disease with complex decision points along the way, which gets back to the point I made earlier regarding a diagnosis. We want to be certain we're dealing with what we believe is the genetic disease, hypertrophic cardiomyopathy, because if we're dealing with glycogen storage disease or a infiltrative process such as amyloidosis, this paradigm doesn't fit. So again, we're defining hypertrophic cardiomyopathy as a disease which is genetic, usually autosomal dominant. Regarding the risk factors for sudden death, family history, syncope, sustained tachycardia, ventricular tachycardia, increase in wall thickness, abnormal blood pressure responses to exercise, significant outflow obstruction, and more recently, late gadolinium enhancement on MRI. This shows up in the guidelines, and I believe, although I have no evidence, that the recommendations are very similar for device implantation in Europe as well. The other area where there's disagreement is how to manage or screen for underlying cardiomyopathies in asymptomatic athletes, where we have, again, differences of viewpoint and recommendations from both Europe and the United States. In the U.S., it's been demonstrated that cardiomyopathies are the leading cause of sudden death in athletes. If we go around the sphere here, one sees both hypertrophic cardiomyopathy, myocarditis, ARVC, dilated cardiomyopathy, sarcoidosis, and the ion channelopathies as a leading cause of death in young athletes. Alternatively, in Europe, Corrado and co-workers here in Italy found much less hypertrophic cardiomyopathy. One also sees arrhythmogenic right ventricular cardiomyopathy and also other issues like myocarditis and dilated cardiomyopathy, but the cardiomyopathies are appearing less often, at least in this population. Dr. Marin led the group dealing with the recommendations from the AHA regarding how to screen individuals, young athletes. We all tend to believe that pre-participation screening is very reasonable. There's overwhelming support for the principle of screening as both a public health agenda and a medical and lay communities. Efficacy of screening strategies is not easily resolved in terms of evidence-based medicine, and issues persist related to methodology and use of ECG and echocardiography. But the mandate to screen is universal. The US and European guidelines are not uniform. In the US, we recommend a very careful history and physical examination, both a personal history, a family history, and a physical examination. But we stop there and don't recommend, at least broadly, the use of testing such as ECG or echo. In the European consensus statement, where Dr. Corrado is the first author, 12 lead ECGs are recommended as part of the process, and this has been picked up by the International Olympic Committee in its recommendations as well. Probably for the Olympics, this is reasonable, but to screen all of the children in the United States with undergoing athletic training would be quite difficult for us from a cost-effective point of view. Corrado and co-workers did follow through, though, and show that this might be beneficial because the red arrow indicates when an ECG screening program was implemented in their facility, and this led to a marked reduction in cardiac deaths, sudden cardiac deaths, after the implementation of a screening program. Dr. Marin then took this one step further and looked at a population in Minnesota, same number of individuals as in the Veneto study in Italy, same follow-up of 2.28 person years, and found that in Minnesota the likelihood of sudden death in athletes was much less. The third study might be the tiebreaker, comes from Israel, where Steinville and co-workers also implemented an ECG screening program at this point in time. And one sees that when the Israeli sport law was implemented, there was a striking reduction in the sudden death in athletes. But the point of their paper was to also go backward before the screening program was put in place. And if one had chosen point C versus point G, one would find no difference in outcome. Their point was that there's fluctuations on an annual basis that may lead to uncertainty regarding how to interpret the impact of the Italian sport law on the Italian athletes. So this, again, brings us back to what the AHA needs to deal with, because unlike Italy, we have a huge population of 5 to 10 million high school athletes, 500,000 college athletes, university level, and 5,000 professional athletes, not to mention all of the other athletes who are not in organized sports. The incidence of athletic deaths is 1 in 200,000 per year. We do have states that follow the recommendations. Many states allow non-physicians to perform high school screening. The universities mandate screening performed or supervised at least by a qualified physician. But the cost of ECG screening in our country would be $750 million per year in an economy which is already straining under its healthcare issues. And we have 1.5 million high school students who require further testing because of false positive ECGs. We cannot perform echo screening. That would be out of the question. And who's going to read all the ECGs? I showed this earlier in a meeting where Dr. Marin was attending. This is a student I saw whose father has hypertrophic cardiomyopathy, but before his father was diagnosed, he underwent a pre-participation screening ECG and was told that he had a normal athlete's heart based upon this electrocardiogram. I don't think most of us in the room would think this was a normal athlete's heart. This person also has hypertrophic cardiomyopathy once his father was diagnosed and came to us. So we need to have experts reading the ECGs and reading them very, very carefully. 10-minute abbreviated echo can be added to young athletic screening, perhaps, but this would need to be carefully evaluated regarding the quality of the echocardiograms and the cost effectiveness of such a process if we're trying to find 1 in 200,000 individuals who may die. And so we are still resorting to the AHA 12-point pre-participation screening, realizing that this is controversial and debatable and not what's being implemented everywhere. And certainly is a point of discussion between ourselves from the US and many of you from Europe who may have different outlooks on how to identify those at risk. Thank you very much for your attention.
So questions?
Bob, congratulations. I don't think I need to twist your arm on this one, but do you think we should go beyond US and Europe and go global? This is because there are so many diseases we know little of, including endomyocardial fibrosis, but also we're beginning to see Chagas disease
Yeah, thank you. I meant to mention Chagas disease clearly because in South America, that's the one of the leading causes of cardiomyopathies. That would fit into a schema of a infectious inflammatory disorder or dilated cardiomyopathy. And thank you for bringing it up. I meant to mention that because if we're talking about Africa, that's different disease. South America, different disease. And with the populations we have that move from continent to continent. And certainly, I think we need to know more about the genetic profile of individuals in developing countries as well regarding dilated cardiomyopathy and hypertrophic cardiomyopathy. We assume it's the same genetic underpinning as the rest of the world, but it clearly may not be.
Can I ask you another question? There's a big deal now going on, at least in Italy, but I think it's catching up everywhere, about cardio-oncology. So who do you think should look after the patients with cancer that have cardiomyopathies due to cancer therapy? Because that's becoming a big issue. There will be separate societies, separate committees. Do you think that's still the cardiomyopathy? Should we be looking after these patients?
Well, that's interesting. I don't think in the U.S. at least we're having new societies, but it is an issue for us because they're very complex patients. And usually what works best is a team-based approach, you know, of a oncologist and a cardiologist, and hopefully a cardiologist who's aware of all of the issues related to chemotherapy, as well as the issues related to the cancer itself, as it may affect the cardiovascular system. So let me know how this goes in your country, and hopefully we'll not have a new society.
So do you think we should probably advise the American Heart Association and the European Society to, in the future, look after probably teamwork and try to develop common guidelines? Because I mean, so there is so much exchange of information that sounds really...
Yes, and this is, of course, is beyond just the cardiomyopathies. This is true for most other diseases as well. And that's been discussed, and there are indeed some guidelines that have been done jointly. I think more cooperation is important. I'm not wedded to regarding the classification of cardiomyopathies to the European or the U.S. system, and perhaps a combination thereof might be a nice way to look at things as well. But I think working together is always a good idea.
Question? Can we hear?
With the Anthony Bates Foundation, and I would like to work together. So I have data, I have screenings, and there are over 300 at least. I think it's over 300 people that are groups that are doing screenings in the U.S. We all need to work together.
Mm-hmm. I agree as to how to find a way to screen in a way that might be accurate and cost effective. And right now it's done pretty much on a voluntary basis, as you know. And my issue with some of the screening issues is that if hypertrophic cardiomyopathy is a leading cause of death in athletes, it's also a leading cause of death in other young people who are not athletes. So we're discriminating against all the non-athletes by screening the athletes. And perhaps we want to also look at screening programs for all young people.
Well, I do all young people.
Good. Congratulations, I agree.